Hello everyone, my name is Dr. Jasmine Sakan. I'm a PGY2 internal medicine resident at Texas Tech University Health Sciences Center in Lubbock, Texas. Today I'll be presenting a case of primary lung adenocarcinoma presenting as pericardial tamponade in a young adult. This case features a 24-year-old Hispanic female who presented to the emergency center with shortness of breath for about 3 days, acutely worsening on the day of presentation. She denied any associated symptoms of fevers, chills, cough, chest pain, wheezing, or palpitations, reported no prior medical or surgical history, no known family history, and was not taking any prescription medications. Denied any illicit drug use, alcohol use, or tobacco use. At the time, she was enrolled into nursing school and denied any new exposures to allergens or chemicals. In the EC, initial vital signs showed no fever, blood pressure of 123/92, heart rate of 121, oxygen saturation of 98% on room air. CT of the chest was done due to the elevated heart rate, showing large pericardial effusion as seen in Figure 1, large right pleural effusion as seen in Figure 2, and 2.6 centimeter pulmonary nodule in the right lower lobe. While in the EC, she acutely decompensated, became hypotensive with blood pressure of 66/57, heart rate of 143, desaturated to 80% despite being on 3 liters via nasal cannula. On examination, she had distant heart sounds with tachycardia. Cardiology was consulted, who performed a bedside echocardiogram showing tamponade physiology. She was taken to cath lab emergently for pericardiocentesis, had 700 milliliters of serous fluid removed. Pericardial tube was placed for 4 days total, draining additional 500 milliliters of serous fluid. Fluid was sent for cytology, which showed metastatic adenocarcinoma consistent with lung primary. For the large right pleural effusion, she had thoracentesis, removing 600 milliliters of serous fluid. 2 days later, pleural effusion reaccumulated, requiring chest tube placement. Lung nodule was worked up further with bronchoscopy and biopsy, which showed congested lung tissue with rare atypical cells. Diagnosis of stage 4 lung adenocarcinoma was made at that time. Oncology was consulted, who did further workup with genetic testing for possible mutations or targeted treatment options. Genetic testing was negative for all but ROS1 gene, which indicated treatment option with ROS1 inhibitors. She was started on treatment during this admission and continues to be on targeted therapy with very close follow-up at the cancer center. Lung cancer is one of the most common causes of cancer-related death in the United States and worldwide. The overall 5-year survival rate is approximately 15%. Non-small cell lung cancer accounts for 85% of all lung cancers and is often diagnosed at a median age of 70. However, about 1 to 10% of these cases diagnosed in patients in less than 40 years of age. Data is limited on the younger population regarding incidence, time trends, and treatment tolerance. Review of past reported cases of adenocarcinoma in the young adults and multiple retrospective studies have shown there is a higher incidence of adenocarcinoma compared to squamous cell carcinoma and is also found to be more common in females. Symptoms can be nonspecific, ranging from mild cough to neurological disturbances, thus the diagnosis is often made quite late in the disease process. In such cases, as these, when pericardial and pleural effusions are present, it is of utmost importance to send fluid for analysis and cytology. Diagnosis is often made with lung biopsy if nodule is present and with cytology when there is fluid present. After initial diagnosis, comprehensive genetic testing needs to be performed as this may help with targeted treatment options as seen in this patient. Thank you for your time.